Dr. Amador, thank you so much for joining me today on Hope Stream. This is such a special conversation that we're going to have, and I just appreciate you giving us some of your time.
I'm glad to be here.
I came across your work through one of the members in our community who, has a son who struggles with substance use, some mental health concerns, and she was just like, "You've got to get out the door on the podcast." So I reached out. You were so generous to reply and give us some time. I was going to try and quickly summarize everything that you've done, and there's no possible way to do that because you've done so much. But you are an expert in
I'm
schizophrenia.
so old. Thanks so much. How many years?
No, you've just done so much. But the things that really stood out to me in your bio were obviously your expertise in schizophrenia, bipolar, some of those really difficult mental health conditions. You served on the board of directors at NAMI and also serving as the co-chair of the schizophrenia and psychotic disorders section of the DSM-4, right?
Yeah, the diagnostic manual.
Yeah. And then worked with, Columbia, everybody. So anyway, if you're not qualified to talk about this, I don't know who is.
I think my biggest qualification is having two family members with schizophrenia and one with bipolar.
Absolutely.
That
And I
would
was
be
just
my
going to ask if
best
you,
credential.
yes, best credential ever. I know people always ask me, "Oh, are you a therapist?" I'm like, "Nope, I have a PhD in real life experience with a child." Maybe you could just give us some background on your personal experience, because I do think that that mostly qualifies you in addition to all of your other credentials.
Yeah, it's interesting. I always had an interest in schizophrenia, and this is before my brother Henry became ill. I look back on my college career, and I was always interested in that. And I was also very interested in insight. People who tend to be kind of repressive and in denial a lot. So my undergraduate thesis was on people who are repressors and brain function. So it's really weird. I was already kind of interested in these topics when, as a senior in college, I got a phone call from my brother who was living in Tucson, Arizona with my mom and stepfather. I was in New York, right? And I pick up the phone and he says, "Come home quick. I killed Dad." Hung up the phone.
Not the call you were expecting.
No, it wasn't. I was shocked. I had the same expression you just had, but of shock. But I didn't really think Henry would have done anything like that because he had never been violent in any way. He had been for about 40 years withdrawing from the world. And I know in retrospect now that was the early signs of his schizophrenia. But I got him back on the phone, and what became really clear really quickly was that he was in a full-blown psychotic episode. One of his delusions, he had many, was that he had killed our father and our stepfather, and was hearing voices. He was hearing the voice of the devil. So I flew him to Arizona. The whole family gathered, of course. My mom and Henry was in his room, suicidal, because he was convinced he'd killed Dad. And my siblings all said, "You go deal with Henry. You're a psychologist," which is a joke. I was 21 and I was studying psychology. I think the reason that they asked me to help Henry was because we were always very close. Even though he was 8 years older than me, he really was. I called him my rock at his funeral. He's since passed away, but it's actually a positive, happy story. I'm not going to focus on his passing. I talked to Henry and I said, "Look, well, you're hearing voices. You think you killed Dad. You didn't kill Dad. Come on." And he said, "Not crazy." At one point he said, "You're the crazy one, not me." I wasn't calling him crazy. I wasn't using those words.
Right.
And for 7 days, I cajoled, debated, and even argued with him. And I couldn't get him to go to the hospital. So I called the police because he was talking about dying from suicide. They were really compassionate. It really worked out well. I prepped them before they came into the house, and he got treatment. And he did really well. The voices went away. The delusions disappeared. He was in the hospital for a month. This is back in 1981, a long time ago. And back then we had hospital beds and we had longer hospitalizations than we have today.
Yeah.
And at the discharge meeting, it was explained to him, I was there, that he had schizophrenia and the medicine he was taking, he'd have to take for the rest of his life. Do you understand? And Henry says, yes, I understand. We get home and he's in his room again by himself. Mom made us there. I'm visiting from New York, so I'm still there. And I was there for a few months. And I'm doing the dishes, and I go to throw a napkin in the trash bin under the sink. And what do you think I found there? His medicine.
Yeah, I'm pretty sure it'd be his meds.
So I fixed the bottle, brandishing the bottle. I knocked on his door, and I said, what the heck is going on? You said you'd take this medicine. And he said, I don't need it. I was like, Henry, 5 hours ago in the hospital. He says, well, that was just to get out of the hospital. Maybe I needed it then. I don't need it now. There was a 7-year period where I argued with my brother. He was homeless for a time. He was hospitalized 4 times a year involuntarily. He was the first person that ever said, I'm not sick, I don't need help, to me. That ended up being a book that I wrote called...
I was going to say, which turned into the title of your book. Yes.
Yeah, that's Henry. That's a quote from my brother. And then I was working on an inpatient unit in my last year of training to become a clinical psychologist. I met this woman, this young woman who was just like my brother. Nothing's wrong with me. I don't need to be here. It's all a big mistake. My mother shouldn't have called the police on me. And I was really frustrated with her like I was with my brother. And I went and I talked to my supervisor because I'm in training, right? I had a supervisor. And as I'm telling him the same story I'm telling you, he tells me to stop talking. So I stop talking. And he says, no, you don't understand. Stop talking to her. Just ask her a couple of questions like, what do you want and how can I help? So I went back out and did that. And she said, I want to get out of the hospital. And she said, I want my mom to stop calling the police. So I told her I would work with her on those 2 things, but one of them would entail her having to take medication. Was she up for it? She said yes. So a light bulb went off. It went really well. I ended up working with her and her mother in an outpatient clinic after she got discharged from the hospital on medication. And it went really, really well. So I had this epiphany. I thought, wow, what I've been doing with my brother, trying to convince him, trying to educate him, trying to demonstrate to him that he had an illness was ass backwards. It was wrong. And so I called him up and I said a couple of really important things, which I often recommend to families I work with. I said, I am sorry for all the times I told you that you had schizophrenia, that you're mentally ill. I'll never do it again. And I'm sorry for all the times I told you you needed to take medication. I'll never do that again. Within 6 months of this big change in me and how I was with him, stopped hammering him with you're ill, you need help. Instead started listening and working with his goals, was able to persuade him to accept antipsychotic medication, and not just any antipsychotic medication, but given by injection. Wow. For the next 18 years of his life, until he passed away being a good Samaritan on the street. He got hit by a car, sadly, but for 18 years, he was in treatment. He went to a clubhouse. It's a place for people suffering from severe and persistent mental disorders. He had a girlfriend. He had 2 volunteer jobs. He was in recovery. He was doing great. And we got our relationship back.
Wow.
So that was the beginning of me kind of rethinking for myself and for the families I was working with, how should we be talking to our loved ones? Don't understand they're ill. The other thing it did is it sparked a research program that I had at Columbia University in New York City, studying this problem. Like, why do so many people? It turns out 50% of all people with schizophrenia and bipolar disorder and related disorders don't understand they're ill. Turns out it's an incredible number, and it turns out that that's a neurocognitive symptom. It's another symptom, just like a delusion or a hallucination. This lack of awareness, it's not denial, and that's a big shift in how we approach the person if they really truly don't understand. stop hammering them over the head with education because see it as being relevant.
Yeah, I was gonna say the term denial comes to mind because so many of us, when our kids are either, struggling with a mental illness or in our case with our families, substance use layered on top of that, and the kids are, I'm fine, I don't need help. We talk about it, and I'd be so curious to get your thoughts on. We talk about that a lot as being in the pre-contemplative stage, right? In the stages of
Right.
change.
5 stages of change.
Yeah, so how do you know? Like, is there a litmus test for, is this person really in the pre-contemplative stage, or is it something different? Like, how do we
Well,
tell?
that something different has a name. That something different has a name. It's called anosognosia. It's a tongue twister. And this comes from neurology. And it's neurological patients who are unaware of things as profound as paralysis.
Okay.
They just actually don't know they're paralyzed. They try to get up out of bed and they fall. And when they're in the hospital, they're restrained. And I'd done a neurology internship, externship rather, and evaluated patients like that. And it got me thinking, maybe this is what's going on with my brother and so many people I'm working with who don't understand they're ill. And so our group and many other groups around the world have studied this problem. The DSM, when I helped revise it 25 years ago, now talks about anosognosia as the issue. The DSM-5, which is our current DSM, goes even further, that this is a neurocognitive deficit and it's not a coping strategy. It's not denial. So there is no pre-contemplation going on. I mean, if you really have no awareness, what are you going to contemplate?
Right.
And hitting rock bottom doesn't work. We're trying to help somebody with one of these illnesses. In fact, it's very dangerous. People,
Yeah.
Food and shelter.
So you said 50%, which is staggering, have this. So I'm just trying to think of how to help some parents who are like, how do I know if maybe they haven't been able to get a diagnosis yet, right? They are in that stage where they're like, something's wrong. It could be denial, but it could also be a mental illness. What would you suggest they do in that in-between time?
I mean, a couple of things. A rough measure, first of all, to answer your first question, is if 3 to 6 months the person has had, let's say they've had a psychotic episode or a manic episode or a depressive episode, and they've gotten some help or they've gotten feedback from family. If after 6 months they don't see it, what everyone around them sees, they seem to be suffering from a mental health condition, they probably have anosognosia. And that means stop trying to convince them, start listening, listen actively, without judgment, without reacting, and listen with respect. So when the person, if your son or daughter says to you, you're the crazy one, not me, I'm not mentally ill, reflect that back. So what you're saying is I'm the one with the problem, not you. You don't have any problem. Did I get that right? That's part of the program we developed called LEAP. And that's the L in LEAP is for listening, but actively and in a way that's respectful and non-judgmental. And that's when you start to join with the person. Right. If the person's abusing substances, I ask them, what's it feel like when you smoke? Well, I feel happy. I feel at peace. And then we empathize with that, with our program. If I was smoking and felt happy and at peace, I'd want to do it too. I think anyone would.
Makes sense. Right. Is that the E? Is the E for empathy?
That's exactly right. Yeah.
Okay. So listening, empathy.
Which is for agreements, looking for things we can agree on.
Okay. Talk about that a little bit.
Well, it's things like staying out of the hospital, things like getting a job and having a relationship, having friendships again. Because so many times with these illnesses, people lose community, they lose friendships, they lose the ability to have intimate, loving, romantic relationships. They lose the ability to work. So there's so many things we can agree on, and the P in LEAP is partner. and then we partner on those things together. There's a few other tools, but these are communication tools, and they're designed to do two things: really validate the person's experience with respect and a lack of judgment, and get them interested in our opinion.
Mm.
My brother never believed he had schizophrenia. I asked him the last year of his life. I didn't know it was going to be the last year of his life because he knew I wrote about him. I had his permission, and he knew I talked about him. And I said, Henry, somebody recently asked me, do you think you have schizophrenia? And I haven't asked you in 10, 15 years, but do you think you have schizophrenia? And he laughed out loud and said, no, I don't have schizophrenia. And I said, so why are you taking these injections every month for the last 18 years? And he said, I do it for you.
Oh, incredible.
Was relationships. And that's what the research that we've done and others have done shows. You can build that relationship where the person feels heard, they feel respected. They will oftentimes do things for us, take medication even though they don't. They'll believe they need it.
That is so fascinating that he did that.
It's counterintuitive, right?
Yeah, for sure. And like side note, I'm very interested in the injection part of it. Is that for compliance? Like,
Yes.
Okay.
Yeah, I mean, when somebody has pills and capsules and they have anosognosia, they don't understand they're ill. Every day, once, twice, 3 times a day, they have to fight the urge to throw the pills away.
Right.
Whereas with injections, once a month or once every 3 months, there's one formulation that's just twice a year.
Wow.
12 times a year or 4 times a year or twice a year. You show up at a clinic or a pharmacy even, like you get a flu shot and you get a shot. So compliance is way better for these long-acting injectables, way better than pills and capsules.
Yeah. And is that approved for just adults, or could an adolescent, like let's say a 16-year-old who's been diagnosed, is that okay?
For children, I have a son who had early onset schizophrenia, 11 years old. It took me a year to find a psychiatrist to do it because there's no reason not to do it. But since the age of 12, he was prescribed an injectable antipsychotic medication because he was pretending to take pills and not taking them.
Right.
And he did fantastic. He's in recovery. He's working. He's doing really well. And he, once when he was 18, he thought about stopping and he wanted to stop. And I talked to him using this approach. And I said, well, it's your choice, son. I totally will respect whatever you do. But just so you know, and I could be wrong, I think it helps you. I hope you'll think about it. And he put his arm around my shoulder and said, it's okay, Dad. I know you're worried. I'll take it. Because I was worried. I was a worried dad.
Yeah.
So again, it was a relationship that led to his acceptance of an injection. So short answer is yes. There's no reason you can't use it with kids.
Okay, that's amazing. And that's like a whole separate podcast. But I'm just thinking about the parent who is trying to sort out also what is the impact of the substance use and what is the mental health concern. Like, how do you tease those apart? Or can you even, like, where do you even begin if you've got a kiddo who's been diagnosed bipolar and they're using a high potency THC vape every day? Holy cow, like that gets really difficult.
It does. It does. And how do you tease it out? Well, first of all, in terms of understanding the psychiatric disorder, you want to see them sober and still having symptoms. You don't want to see them, but if you want clarity, they're still having manic symptoms, grandiose ideas, or delusional or hallucinating. When we know they're not, so then they've got both conditions.
Okay.
The substance use disorder and the psychiatric disorder.
Right.
What I try to do is and what I coach families to do is to not judge and not complain and not educate and instead use the leap approach. You actively listen to the person, be empathic. And part of the empathy we teach is normalizing. So, son, you told me that when you smoke, you can sleep better. You can be chill. I can see why you do it. I do it too. This is for normalization. I'd do it too if I was in your shoes. And the kid says, so you're saying it's okay. And you give your opinion with this approach. You say, well, comes, and there's the 3 A's we call them. I'm sorry. We acknowledge our fallibility. We ask the person not to argue. So here's what it sounds like. I'm trying to understand how it is. Do you feel like I understand what it's like for you when you smoke? And he said, yes. Right. And this sort of archetypal conversation we're right now. And you've asked me, do I think you should keep smoking? All right. Well, I'm sorry. And I could be wrong. I think it's a good idea not to smoke. For you to stop or, stop vaping. And I hope we don't have to argue about this. I'm sorry I have this opinion because I might upset you. I could be wrong. I think you should stop. I really think it'd be better for you if you stopped but I don't want to argue with you. Take a very humble approach to giving your opinion and do that after there's a foundation of your kid feeling heard and appreciated and not criticized and complained about.
Yeah, it's definitely I can just feel how that lowers the defenses, right? Because you're not being combative and you're not being confrontational. You're really coming alongside as kind of a partner. And it sounds like it aligns beautifully with the craft approach, which is what we teach, community reinforcement and family training, where you are really curiously trying to understand what is this doing for you, which is different, like from a substance use standpoint, what is the weed doing for you, or what is the alcohol doing for you? But you can't really say that when it comes to a mental illness, like what is your bipolar doing for you? Right? It doesn't make sense. So that's, I think, so why this leap approach is so beautiful is because it works with something that's so difficult, especially if you yourself have never experienced a mental illness like that. It's so hard to relate.
Yeah, it is. And I mean, people with psychotic disorders who have anosognosia are some of the loneliest people I've ever met. Everyone around them is telling them that reality is false.
Right.
So, if the person is delusional, I love talking about the delusion. So tell me about the CIA conspiracy. I can see why you're scared. I'd be scared too. Well, do you believe me? I could be wrong, or I'm sorry I have this opinion. I don't see the same thing you see. I'm doing the opinion tool again. I argue with you. You don't you can't talk somebody out of a delusion. But what you can do is join the person emotionally, with how it feels to them, what's going on.
Yeah.
And validate their feelings around it. Not the same as agreeing it's true.
Right.
It's not the same.
That's a big distinction, because I do know a lot of times when we're talking about motivational interviewing or with craft and we're talking about, curiosity and using reflections and using, affirmations, parents are like, yeah, but I don't want them to think that I approve of this. And the way that you just phrased that so elegantly does a good job of, connecting with them, but not giving your stamp of approval. So that's a big, big difference.
Yeah, it's validation, not verification. No, it's not saying I believe you. It's saying I understand you.
Yes. The other thing that we see a lot of that I'd like to get your thoughts on is young folks who are using these high potency marijuana products, 90 to 100%, daily, multiple times a day. And they are starting to have psychosis and psychotic breaks with no history in the family, right? Just, it seems to be, and the jury's probably still out, it seems to be very directly related to the THC. And I'm imagining that this approach obviously still works with someone like that. If they're having these, we have moms who are like, oh my gosh, my daughter's in the grocery store thinking that, somebody's trying to kill her in the grocery store. Never had this problem before. What are you seeing with that, this kind of convergence of psychosis and marijuana?
I see it a lot, and I actually don't think the jury's still out. When I look at the research, and there's a lot of research on this, it appears that the high potency THC is triggering the onset of the illness.
Mhm.
You know, and it could be that somebody had some vulnerability to the illness, maybe not family history, but other things that can make you vulnerable to the illness. It seems to be triggering, if not causing, the onset of schizophrenia and related psychotic disorders. So yeah, smoking at a young age and smoking these high potency. Look, when I was much younger, I smoked a little bit. I didn't like it, luckily. My brother smoked a lot. He loved it. I don't know if that's why he got it and I did. Why he got schizophrenia and I didn't. You know, I don't know. We do have a family history in our family, but the research is pretty clear that excessive use of THC in adolescence and early adulthood is associated with a much higher incidence of schizophrenia.
And that could be, do you know, can that be then reversed if they stop? Or
Yes.
it can? Okay. Because that's a big question that parents are having is like, oh my gosh, what, if I can get them into treatment, do we have a chance of reversing this?
And by reversing, let's make sure you and I are on the same.
Yeah.
What I mean by that is if they can get sober and get into treatment for the schizophrenia, they can get into recovery.
Okay.
That's what I meant by reverse.
Okay.
It's not as if they stop smoking and then they don't have any more psychosis.
Okay.
You still have to treat the psychosis because the threshold has been passed, and they now do have that psychiatric disorder. You do have to treat that separately.
Okay. That makes sense. I would imagine that so I know you do training, professional training. So you're spreading the word to providers, therapists, law enforcement. Like, how does this work? Because I know so many of our families, they have to call 911 because things are just so out of control. And often that can be not helpful, depending on how, well trained the police are that are showing up. What does it look like when you look at the law enforcement world and, more people having these psychotic breaks? And, oh, I can see that going so wrongly if they're not trained. How's that going?
Well, they've gotten a bad deal here, the law enforcement, because the failure of our outpatient psychiatric care has left them being the first responders. So we train police officers, sheriff's deputies, and EMTs in using this approach, and it's very streamlined. It's a way, we teach them ways to use these tools to quickly de-escalate the person if they're agitated, and to gain their trust, and to get them to the hospital. So it's very focused on gaining trust and de-escalation and getting the person to the hospital. And these officers and these EMTs love the program. It really makes sense to them. I get a lot of good feedback after the trainings from people that it helped them.
Yeah.
So we're training not only police officers and EMTs, but 911 dispatchers. When somebody is psychotic and calls 911, how to help that person de-escalate and stay put while the police come or the crisis team comes. We teach judges. We've taught hundreds of judges because many judges are doing mental health diversion courts.
Right.
And they're trying to convince the person, don't go to trial, go to treatment. We want to divert you to treatment. And they've got people saying, I'd rather go to trial because I'm not mentally ill. There's something wrong with me. I'd much rather go to trial. And these poor judges are like trying to get the person to accept the diversion that they can offer them.
Yeah.
So we train judges in this approach as well. And most important, we train families. So there's three groups: criminal justice, providers, clinicians like myself, and family members like myself.
Yeah.
Those are
So
the
how
groups
does that
are
work?
really
Like
the
if,
stakeholders.
yeah, if one of our families is interested, what is available to them that they could tap into from I know you're working on a really cool AI thing. So tell us a little bit about how a family could get some help.
Well, in November, we'll be launching our Leap AI coach, which is really cool. We just piloted it and got great responses from 300 people who tried it. We're just doing some fine tuning. And what it does is, as one person said, it's like having Dr. Amador in my ear. You can ask it any question. That sounds kind of
It's amazing. Or in your back pocket or your purse.
I like that better.
Yeah.
Yes. But well, first, the easiest thing to do, and it's all this is all free. We're going to have to charge a little bit for the coach because we have to pay every time you
Sure,
go
of
to
course.
OpenAI. But you can go to leapinstitute.org, leapinstitute.org, and there's free videos under resources. There's about 24 videos. There's a TEDx talk that people, over 500,000 people have watched, and they love it. They say, this really helped me to understand that my loved one has this symptom. They're not in denial, they're not being difficult, they're not being stubborn. And then we have acted out scenarios where, we have actors together with me acting out how to use Leap. So all that's free and available
Okay.
at leapinstitute.org. You can also certainly read my book. There are some excerpts free on like 4 or 5 chapters I donated to NAMI, so NAMI.org.
Nice. Okay.
Or you can buy the book.
Buy the book. Buy the book.
It's an ebook, audio book, and print. It's all free.
Yeah, I want to just go back. Those are all amazing resources, and we'll put those in the show notes. So if you're listening, don't feel like you have to write it all down. It'll all be in the show notes. But I think what you said was so important. I don't want to skip over it. Is that, and I'm going to try to say it, anosognosia. Is that right?
Anosognosia.
Anosognosia is a
Perfect.
symptom. It's a symptom. I think that's so important to understand because I think that's flipping it a bit from what people typically think is denial or is this sort of pre-contemplation. So I just wanted to highlight that because it's so important.
Yeah. Well, can I add to that?
Yeah, of course.
Real quickly. The families and clinicians I work with and police officers say, well, this person just refuses to admit. And I'm like, no, it's not that they're refusing to admit. It's that they cannot comprehend. Would you ever say somebody's refusing to stop hallucinating?
Of course not. Yeah.
If they can't control it.
Yeah.
It's the same thing with the belief that I'm not ill, the anosognosia. It's not a choice on the part of the person. It's brain dysfunction.
Yeah. That's so important. Do they ever get to a point where they then do recognize, like you said, your brother, forever said, no, I don't have this. Do they ever, or I guess this is an individual thing. Do they get to a point where they can recognize it?
The research shows that most people are like my brother. They tend not to understand. Even when successfully treated, all the other symptoms are treated, about 75% still have anosognosia. The medications don't seem to help with that. There might be one exception, clozapine. It's generic, so I'm not trying to sell anybody's drug here. Clozapine, there's some minimal research indicating that it might lead to insight into awareness, to reducing anosognosia. But most people don't respond. Now, the other side of that number is, about 25% do gain insight after being in treatment for a couple of years. The anosognosia does remit, just like the hallucinations, delusions, the mania remits. And with bipolar disorder, we see anosognosia kind of waxes and wanes. So during the depressive periods and during recovery, in bipolar disorder, the story's a little bit better. People tend to gain awareness. Interesting. With consistent treatment.
Yeah. And when you say treatment, I understand the medication side of it. Is it also then mandatory to have more like talk therapy, psychotherapy along with that? Or when you say treatment, are you primarily talking about medication?
I'm primarily talking about medication, but by all means, psychotherapy, psychosocial supports, socialization, and there's all kinds of structured places where you can get socialization. But definitely having a psychotherapist is really important if you've got one of these psychiatric illnesses, because you're in recovery, you're trying to get your life back, and there's a lot of challenges. So having someone to talk to. There's a caveat here is that there's also CBT, cognitive behavioral therapy, for psychosis, because about 20% of people don't respond to medication, and many of them do respond to CBTP, cognitive behavioral therapy for psychosis.
Okay.
So this is really an exciting area where talk therapy is actually helping with the hallucinations, the delusions, the mania.
That's so interesting.
Yeah, medication is the cornerstone, but for many people, CBTP can really make a difference as well.
Okay. Yeah, I asked because I thought, so if you're seeing a therapist, but you are not aware that you have a mental illness, it could be a little tricky from the therapist standpoint. And I would imagine that therapist has to be extremely well trained in schizophrenia or in bipolar or whatever it is, so that they're not hammering them on the exact thing that you don't want to hammer them on, right? Okay.
I like that you use the word hammer.
Yeah, well, I think we're really good at that. Yeah.
That's what it feels like. Why are you telling me about this schizophrenia thing? I don't have it. Man.
Yeah. Yeah.
Frenzy one, not me.
Yes.
It does feel like the person's being hammered.
Yeah.
And I did that for 7 years, so I don't criticize anybody who does it. I get it.
You're a pro at it.
And unfortunately, I am.
Yeah.
But I learned to stop doing it. I learned to put the hammer away.
Yeah.
Stop educating, start validating and joining with the person.
Incredible. Well, I can't thank you enough for this. So insightful. I know everybody's going to jump to the resources because it's such a difficult and confusing thing to experience as a parent when you have zero training and, zero insight into what's going on. So I think this is going to expand a lot of people's understanding, and we'll put them in touch with your tools. Good luck on your launch. I'm sure
Thank
we
you.
will.
We're excited.
Yes, if you need any test users, I'm sure we could gather up a few for you.
All right. Well, our testing period's over, but
okay, so the real deal is coming.
Yeah, and you can ask it any question you want. My son just accused me of poisoning. What do I say to him? And it'll give you the LEAP approach for how to start talking to him about it.
Amazing.
I mean, any kind, how do I convince him to take medication?
Right.
It'll walk you through the steps.
Incredible.
It's really cool. It's kind of, it's giving me a lot of solace that when I'm gone, this will continue without me.
Yeah.
Besides the book and the rest of it.
Absolutely. Okay. Well, thank you.
That's amazing. You're very welcome.
I appreciate
Thank you
it
for what you do
so much. Thank you.
You're welcome.